Again, hello everyone. Welcome to the National Pilot Webinar, the monthly webinar. We had more people that wanted to register for the meeting than the Zoom regular account couldn't handle. So we upgraded it to a webinar session, which is a little bit different than the normal sessions. I do want to continue the discussion. So if you have a question during the session, please raise your hand and I will try to scroll through the attendee list and allow you to talk so you can ask your question. Again, these calls are recorded and the meeting will be posted to the YouTube channel, the NBSTRN YouTube channel after the meeting. So our agenda for today is we're going to have a presentation from PerkinElmer about a congenital megalovirus, a CMV assay from Eleanor, and then if we have time for the meeting, we will hear from the pilot teams, or we will have a couple announcements, one from APHL, and then we also have an announcement from the CDC. So with that said, I'm going to hand it over before the presentation to Ki Chan to make an announcement about an upcoming research summit.
Hello, everyone. Welcome to the National Newborn Screening Pilot Call. Thank you, Dr. Taylor, for letting me have some time to share with everyone our very exciting Newborn Screening Research Summit. So you're probably wondering, we just had the network meeting, so why do we have this summit here? Well, we want to highlight new partners that are working in newborn screening research space, rare disease, in particular in screening, diagnostic, and treatment. And so we welcome you and your colleagues to this two-day event. It is on September 28th to 29th, which is Wednesday and Thursday, and it's from 12 to 5 p.m. Eastern time. I do want to highlight that we extended the time. So if you in our last month, when we had to save the date, it was from 12 to 4. So I do want to let everyone know that we did extend the time. So the new time is from 12 to 5 p.m. Eastern time. So definitely mark that in your calendar. And so the theme for our Newborn Screening Research Summit is what is old is new in data science, treatment, and diagnostic testing. We have an awesome lineup of speakers that's going to talk about many different avenues of newborn screening. And I'm just going to highlight the main big topics. We're going to have a group from Jackson Lab that focus on phenopackets, which is linking phenotype description with genomic information, who's also working in collaboration with Oregon Health and Science University with Dr. Hendel on the Monarch initiative on monitoring genotype and phenotype data. And we also welcome new members to our NBSTRN network, who's going to also talk about new therapeutic strategies for rare diseases, using new mechanisms, specifically using clinical whole genome sequencing for diagnostic testing from Myome. So we also have some new members joining from industry as part of our research summit. What is old and new? So, congenital heart disease is one of the conditions being screened, but we're also we also want to hear from researchers that are thinking of ways for making a more specific testing. And so we're going to hear from groups that are going to focus on using machine learning to help improve screening and diagnostic testing. And then we're also going to look at new therapy in rare diseases that you'll hear from Duke University, from a group from St. Jude's that's looking at CRISPR gene therapy. And while we have all this new therapy and new treatment and diagnostic testing, we want to be cognizant of the ethical, legal, and social implication of all these new rare disease advancement. So we're also have a presentation by St. Jude's and looking at the informed consent process for gene therapy for sickle cell disease. And then we're going to have also members from industry that's going to look at what are they developing in genetic testing for hearing loss, and also a group looking at SCID and ClinGen curation. So we have a very awesome lineup of speakers and topics, and we welcome you and your colleagues to register for the summit. I'm going to type the summit link onto the chat. So while you are listening to our presentation. It would only take a few minutes for you to register for the summit so that, it's inside and in mind. So, out of sight, out of mind, I'm going to type in the chat. We'll love to see an increase of registration during this call. So thank you. And we look forward to seeing you at the summit.
Thanks, Key. I saw that Dr. Pesh had her hand up. I'm trying to find her. If you guys just bear with me. Dr. Pesh, I need you. Are you able to speak?
Oh, sorry. No, that was a mistake.
Oh, okay. All right.
My apologies.
No problem. All right. If you guys, we're going to continue on with the speaker. If you guys do have a question, please use the raise hand feature and just bear with me and I will try to unmute you as fast as I can. With that said, Eleanor, I do have an introductory side. So now we're going to hear us talk from Eleanor. She's a senior application specialist in medical diagnostic development at PerkinElmer, and she's going to be presenting her presentation on the Neo MDX CMV real-time PCR assay, a dry blood spot-based high throughput compatible RUO workthrough. And with that said, Megan, I am going to stop sharing my screen and hand it over to you.
Okay.
Let me know if you have any issues.
I do not see an option for sharing my screen, actually, in the Zoom.
Give me 1 second, because I don't think I upgraded you to full panel. Let me see.
Okay.
Sorry for the technical difficulties, guys. I see you. I don't see you as a panelist anymore. And you're not in the participant list, so I can. Can you do me a favor and raise your hand, Eleanor, so I can see you in the, oh, there you are. Okay, gotcha.
Maybe she could share her slides and then you can present slides for her.
So you should be, you're now a panelist. Are you able to see the?
Okay. I see the option now. Thank you.
I think a lot of people are asking the question, Eleanor and Jennifer, if the slides are going to be available.
Yes, I will send out or send a PDF of the presentation to Jennifer after this.
Thank you.
Okay. Can you all see my screen?
Yep.
Yes,
Okay.
you're good to go.
So as Jennifer introduced me, I'm Eleanor Doherty, Senior Application Scientist here at PerkinElmer as the Technical R&D Lead for this project. And I look forward to sharing my project details with all of you. So as many of you might know, in this very targeted group that cares about newborn screening, that congenital cytomegalovirus is a virus that is prevalent in newborns, and it can cause permanent health issues when that is transmitted prenatally. It's the leading non-genetic cause of hearing loss in newborns, And the current protocol is to do retroactive testing after newborn hearing tests are failed. And this is insufficient as it misses late onset patients, as well as the very early stages where antiviral treatment would be an option to minimize future sequelae. Also, the current one of the workflows for universal screening is based with a dried blood spot card input, and then sample extraction and molecular testing by means of like qPCR and analysis of those results. So that's why here at PerkinElmer, we wanted to try to make a dried blood spot based assay to detect cytomegalovirus. Dried blood spots are not the best input for detecting CMV, but it is the universally collected sample. So while there's higher viral loads in saliva or urine, it doesn't require a paradigm shift in the hospitals during collection. And so we wanted to use our kind of existing newborn screening related chemistries with a NeoMDX elution solution and the base formula for PCR reagents to target this disease. So made a group of products that are both in the 96 well format and 384 well format to support both low throughput and high throughput use cases, whether it's high risk retroactive testing or larger. And so it covers from extraction of the DBS to running the qPCR with the reagents. There's 2 vials in the reagent kit, and they are added at a 1-to-1 ratio, which makes it user-friendly. In addition, there's a base color that's actually pH sensitive, so it's easy to tell in those like large 384 well plates if the master mix is in there, as well as was the sample added appropriately, because there's a distinct difference in color between those. And then a control card that follows the samples from the very beginning to the very end, because they are punched as well. So they go through the extraction and then followed into the qPCR. This has already launched this year and is available on our website. Just look up PerkinElmer CCMV, it will come up. As for the extraction workflow, it's a relatively simple workflow that's has minimal hands-on steps. It takes about half an hour. As I mentioned, the controls follow through the whole process. And there's also a few consumables. There's only 1 extraction plate is needed, 1 solution, which is the elution solution. And then it goes into the final qPCR plate. The steps can be described as, punch the DBS cards. There's like a 1-punch option. Then you wash those with the elution solution, and then you elute the DNA with heat and shaking. With this input media of DBS, we do have a option that if there's DBS availability, you can do 2 punches in 1 reaction well. When this option is chosen, the final elution solution volume is increased slightly to compensate for that increased absorption that DBS card is done. And a reason for this is it does increase the sensitivity that we're able to achieve with this increased input. Both of these workflows are both manual and automation compatible. PerkinElmer has Janus liquid handlers that can do 4 extractions at once and then condense into a final qPCR plate. And one of the great things about this is that it's scalable. You can do incomplete plates or full plates. It doesn't have that limit in the process. So after the extraction occurs, the PCR mix is made with the 2 PCR reagents. As mentioned before, they're added in a 1-to-1 ratio. And in totaling 5 microliters of reagent master mix, and then 10 microliters of the extracted sample is added. You seal the plate, vortex, spin it down, and then run it on any thermocycler. With the colors that we chose for this assay, it was FAM and the Sci5 channel. All those major thermocyclers out there with qPCR instruments, they can look at both of those channels and distinguish it. So if you have a Bi-Rad, Roche, Light Cycler, or any of the QuantStudios or the Ionis Q, it's compatible. And then with the result interpretation, it's pretty straightforward and a simple qualitative, yes or no answer. With any qPCR result, you should look at the controls first and see if they pass. So a non-target control is one looking for contamination. The C1 control is positive only for the RNase-P housekeeping gene and negative for CMV. And then we have a C2 one, which is a low viral load, positive control, and then C3, which is a high viral load control. And then we have the DBS samples with does it detect CMV and any of the at all, and then is the RNase-P there. For these, yes or no's for the 2 target channels, we have a simple result interpretation. If there's CMV amplification, regardless of the RNase-P presence, CMV is detected. And then if there's no CMV and RNase-P is detected, it's a CMV negative sample and it's valid. But if there's no CMV and no RNase-P, that's an invalid sample. It will need to be retested by leftover extracted DNA from the extraction plate or re-extracted from the DBS card or recollected from the patient, the fable. As for the assay performance, this is an RUL assay, and it's a newer product, and so we haven't run, clinical trials for this. It's the nature of coming out with a new thing, and so what we did have available though is negative samples and a proficiency panel of real CMV positive results of unknown titer. And when these were tested with 12 duplicates for each of the positives, and then 180 of these negative newborn DBS, we have the metrics seen here with a 98.6% accuracy, 100% positive predictive value, 100% specificity, and 95.2% sensitivity. But again, that is with this panel of 8 samples and negatives. So there's it's not a clinical trials metrics, and future studies would need to be done, but that is a total of 276 samples for these metrics. And then, as well as the previous slides panel, there's a verification panel that is commercially available, and this has known viral loads. And when this was run again with a sample set of 12 for each, we're able to detect reliably down to 5,000 international units per mil, and then unreliably down further. So, and but when actual LOD studies were done for just the PCR chemistry, this is with a direct input and not from real DBS samples, we could get down to 3.3 international units per reaction. So that's the capability of our PCR with no inhibitors from true samples. But when the full workflow was looked at with DBS and extraction and then put it into the PCR, the LOD from that study was 10,000 international units per milliliter spotted on DBS. And then at PerkinElmer, we have a genomics division in Pittsburgh, and they've run 45 retroactively tested DBS, and they found 3 CMV positive ones. So it's a really small sample set, but of those, the CMV positive CT range was about 30 to 34 CTs. And then the QCMD 2021 cytomegalovirus dried blood spot testing program was also run by the Pittsburgh Genomics division, and they got all 8 of the samples correct. So 7 of those being positive and 1 of those being negative, which is again another external kind of way to test our assay's performance. And then with PerkinElmer, we also have a SCID SMA DBS-based qPCR assay. This process is has been submitted to the FDA for IBD. It's a more it's not at the level of our CMV one, being a new RUO. It's been further developed, and they have a longer workflow for the extraction. And just want to highlight that the PCR chemistry of these are compatible, but there are differences between the workflows. The CCMV one is a more simplified version, and the differences between the two are highlighted here. There's an additional wash step, and it's with a wash solution as opposed to just the elution solution for the first one. And it has longer shaking and heating steps. And the data is not shown on the slide, but they are compatible. The extraction from the SCID SMA extraction workflow can be used as input in the CCMV assay. And then here I do have some of the data between these. So I've highlighted 3 different workflows as options. And so with the first one being just 1 DBS as the input and a 50 microliter elution volume. The second one being 2 DBS punches with a slightly increased elution volume, 65 microliters. And then this last extraction workflow, the third one, which is used for SCID SMA, it has the longer protocol and a 80 microliter elution volume. When all 3 of these extraction workflows were compared, it shows that it can be used, but they do have different performances. With the 2 DBS inputs being able to reach the lower sensitivity. We see these different groupings, and it can go lower. But 1 DBS punch is able, it is working as well. And so with that, I'd like to stop and open for questions. You can email either myself or Stephanie, who is the R&D manager for this project, or email specialty diagnostics at perkinelmer.com, which is a email also available on the website.
Thanks, Eleanor. This was a great presentation. You have a number of questions in the chat. Some of them you kind of addressed as you've gone on about the DNA extraction method. So it sounds like you've tried 3 different types of extraction methods. Do you have any information about other extraction methods, things that haven't worked well with you while using this process? Things that may miss some positive results. Do you have any other further information about that? I think you kind of addressed the 3 different workflows that you guys have.
Yeah, there's been other ones that we've tested as well. The Extracta elution solution, thermal shaking, which you see it can be seen in previous publications, and these comparisons, I think, have been presented in different conferences, and those posters are also available on our website online if you would like to look at the data more. But one of the findings of this is that there's a higher sample input that's able to be tolerated, with our extraction workflow. So, we're able to add 10 microliters of sample into the final PCR, whereas some of these other extraction methods do not clean up the DBS as much, and the inhibitors that are added, they can't be added as much. So you would have to have a reduced sample input to be able to see the detection, because it might completely drop out. So there's trying to think what other methods. I don't have the data readily available with me, but that can be looked at more online.
Thank you. And I just wanted to let everybody know that if some people are already putting questions in the Q&A button on their chat. I think we do have a couple people I'll try to find. Barb put in there, and you did address this in your slides, can the same extraction for the NEO MDX SMA TREC assay? And I think you hit on that as well. But
Yes.
Can you discuss if it could be used for the larger sample sizes? Was that something that you guys tried out? Like with the larger like multiple punches?
Okay, so with this SCID SMA extraction method, or with that assay, it's like CE IVD bound. The protocol can't be changed for that workflow. And so the intention is to completely adopt that workflow for the use of the CCMV assay, because the CCMV assay is just RUO, so it can have those variances in workflow because there is no official FDA approved workflow. And so using 2 DBS with the SCID SMA extraction workflow has not been tested. In this, what I've shown. However, in the early research stage of this project, that is what we started with. And we wanted to see if we could, how much could we simplify and shorten our extraction workflow, and without, compromising, our sensitivity. And this simplified version is what we came up with. If that answers your question. Is there any other questions?
Oh, I'm sorry, I was muted.
Oh,
Barb, I unmuted you if you wanted to ask for further details. And then May Baker, you're next. I unmuted you for your question next. Barb, did you still have a question that you wanted to ask? Okay, we will go with May Baker. May Baker, you can go ahead and ask your question.
Okay, and could you get your slides 8?
Okay.
So I'm trying to understand, let me see, that's the right slide. So first, sounds like you use the CT to define your control accepting criteria, right?
Yes.
I want to ask, so if you use CT, do you have the fixed threshold, like the signal intensity? Because you have to set the intensity threshold, otherwise CT can be any.
Yes.
Okay.
That's a great point, and try to highlight that in this little asterisk that
Oh, I
these were specifically based on like one particular instrument, the Quant Studio 7, with a particular extraction protocol, because obviously if we had the 2 dBs of these controls as well, we would be expecting a different value. And then it is with a particular threshold that was on that instrument, and they are subject to change with different real-time PCR instruments, and that would need to be, you know, optimized for that with a set workflow and the instrument.
okay.
Because CT values are very, you know, misleading without all those other aspects. I mean, they're relative to the settings. You're correct. So this is kind of a guideline, but it would need to be personalized to the lab schemes.
Yeah, I think you need to emphasize maybe even more, but you said it very well. So another question is on this slide, if I understand correctly, and you have, if you see the CME signal, but you, no matter what, you see your reference gene, whatever, right? So I understand that, but I think the third category, if you, when you say N means 0 or means low, because you set a threshold. So I just want to get confused, because if you see the NSP application, but not to the degree, you still in the position not detect CMV, am I right?
Yes. So the rationale for that is because if we're seeing the RNAsP signaling higher than like 35 in, you know, this scheme for the Quant Studio 7, I'm attributing that to contamination. If it was a real sample and the extraction was successful and expecting lower CT values, if the, you know, if it's higher, you know, I would call that invalid, because either, you know, it is improper extraction, maybe the DBS, you know, came out with these, you know, DBS-based workflows, and dry labs, DBS can fly out of the plates during punching or during the liquid transfers, especially, you know, if it was like an automated system where a user isn't observing it the whole time, you know, maybe that DBS sticks to a pipette tip and comes out at some point in the extraction, and it wasn't a complete extraction, but there's going to be something there. That's why we would call it invalid and want it to be retested, because it might be one of those use cases, which means that it wasn't properly extracted. So if there's no CMV, it could just be from not being indicative of that real sample.
I do understand, but I think let me ask a different. So when you say N means 0 signal, or also conceptually including low signal? That's my question. The key thing is when I have a 0, that's a no-brainer. But did you have a criteria for low reference gene? Because if low is potentially also indicate maybe you didn't have a capability detect CNV. So that's what I want to understand. If too much time, and we can talk offline.
Okay.
Yeah, maybe we should move on to the next question. We have a couple more. Suzanne Cordovado has two questions. The first one was, what's the source for the commercial available validation panel?
I don't recall offhand. I know Randox or EDX is one of the commercially available CMV positive sample sources that we used, that it is reported in international units. And the QCMD one, I don't recall where that is from, but if it's something I could look up after if you'd like to email me.
Okay. And then she asked another question, and Suzanne, you might want to unmute yourself about this. It says, can you share what CMV gene targets the assay integrates? I'm assuming she means the CMV sequence, but Suzanne, if you raise your hand, you can ask the question in person. Can you share the sequencing target for CMV?
We do share the gene name in the IFU. I think it's L6.
Suzanne, I finally unmuted myself. So it's L6?
I believe so. Sorry, I don't want to misspeak. It is in the IFU, which is available on our website. At the bottom, there's some different links for the material that we have.
Fantastic. Thank you so
Mhm.
much. Also, the QCMD, I just put in online QCMD, CMV, and it did come up. So thank you.
Oh, okay, great.
And then Richard Houghton asks, what's the final reaction volume template plus the reagents?
Yes,
Is it-
so the 15 microliters in total, 5 microliters being PCR mixes together, and then 10 microliters sample input, and that's to be used for both 96 well formats and 384 well formats, not to increase the volume like some other assays. It's constant between the two plate formats.
Robert Vogt, I allowed you to talk, so if you have a question, go ahead and unmute yourself, Dr. Vogt.
Okay, am I present?
Yeah, we can hear you.
Great.
Hey,
Thank you,
Bob.
Jennifer. I'm just, this is just being annoying, I guess, but May's question was so important about, what is the CT? And actually, none of these numbers on here are the CT. The CT stands for cycle threshold. And that is the question that May was asking. What is the setting that you use to determine the crossing point, which was designated in the first nomenclature proposals as the CQ, which is the quantitative cycle, the value that you use to determine whether the reaction is positive or not. And I'm sure this isn't going to change, but really all these things, everything on here, the 35, the 20, the 24, et cetera, all of those things are the crossing point, which is another name for it. But the designation for that should be CQ, and the CT should be the cycle threshold that is set by the in whatever way. And there are a bunch of different ways of doing that. And it can also be not set at all. It can be calculated from the inflection points on the real-time curve. And there are softwares, or at least there used to be softwares in some of the qPCR machines that would do it that way. So it's a critical question. I really appreciate May bringing it up. And I think it's not helpful to have confusion between what a CT is and what it isn't. So that's my that's my political statement of the day.
No, thank you for that valuable lesson on that. That is really, important to distinguish.
Yes, we still are striving through standardization and terminology standardization as a community, which
Mhm.
I think that affects a lot of different communities as well.
Now, on the paper that Jennifer published in, what was it, 2016, Jennifer, is that right?
Yep. Hmm.
The Trek SMN paper, we did use CQ, and that took some convincing to do that. But in that paper, I hope I'm right about that. I should go back and look and make sure. But I think this is going to become a more commonly used technology, real-time PCR for quantitative purposes, and that it's kind of fun to go back and read. It's called the MIQE, Minimal Information for Quantitative Experiments. It was published, I think, first in Nature and then kind of copied by Clinical Chemistry back around the turn of the century or some such thing.
Well, thank you again, Bob, for your comment, and thank you, everybody. Thank you, Eleanor, for your presentation, and thank you, everyone, for attending. Dr. Wilcox puts an interesting comment in the chat about how Georgia considering CMV testing. Just to conclude this session, I was just wondering, Eleanor, if you can talk about next steps for this RUO. Is there any plans to test it out in a state program in real time? I know that some of the pilots have compared the dried blood spot versus the urine testing. And so just wondering what your future plans are.
Definitely, if any of the states are interested in running a pilot study, we'd be very happy to support that with reagents. I don't know if Stephanie is on the line. She knows more about the relationships that we have with other state labs.
Let me see if I can get it really quickly.
Yeah,
Uh,
All right, Stephanie, can you speak now? Can you unmute yourself?
Hi, everyone. Can you hear me?
Sure,
Yes.
yes.
Okay, great. Yeah, so we're really excited to have the congenital CMV for dried blood spots be as an RUO on the market. And as Eleanor said, we are keen to collaborate and do pilots with any state that is interested in running our assay. We do have a couple pilots ongoing right now, and sort of to honor our confidentiality agreements, I don't really want to say much, but we can definitely will be either publishing data that will supplement what Eleanor presented today, as well as be open to discussions to anyone in the future. So please feel free to contact us. We're keen and gearing to go. CMV is a really hot spot right now, and so we just want to make sure that everyone knows that PerkinElmer is a resource for you, and we'll be glad to talk to you about any of this.
Thank you, Stephanie. And if I can take it back over, I just wanted to close out the session with a couple announcements. Eleanor, do you mind stop sharing your screen so I can share my screen?
Right. Did that do it?
I think you're still sharing.
Oh,
There you go.
okay.
Let me see if I can get we have one announcement from APHL. I don't know if Kashia is still on the call. I will try to, if you raise your hand, Kashia, I can unmute you, but the main announcement for them was to register for the APHL Newborn Screening Symposium. There you go. Here you go. Okay, Kashia, go ahead.
Oh, okay. Yeah, and so it's basically what you just said. Registration is still open for the symposium. Also, if you need to register for continuing education credits, you can do that on the symposium website as well. And if you have any questions about the symposium, you can reach out to me or Dara or anyone on the APHL newborn screening team. So thank you. Bye.
And finally, I will hand it back over to Dr. Ki Chen for a few more announcements from NBSTRN and then one announcement from Dr. Robert Vogt. Ki?
Yeah, hello everyone. We like to share that we have 2 publications by NBS Trend, and we want to thank all our co-authors who participate in writing this manuscript. This manuscript is there's a companion paper. There's part 1 and part 2. Part 1 is the population-based screening of newborns, findings from the newborn screening expansion study. This is a review of the newborn screening expansions and the role of pilots. Our companion paper, which is part 2, addresses these challenges that was elucidated from the expansion study. And so part 2 focuses on models that can help design pilots. And so that's population-based screening, findings from the newborn screening expansion part 2. So they're both available open access at Frontier in Genetics. Next slide. And we also want to share that we have our newest episode that's been aired at the Newborn Screening Spotlight podcast. It's available on Apple Podcasts, Google Podcasts, Spotify, Amazon Music. So definitely check that out. Our latest episode, episode 14, is about the ethical, legal, social implication of newborn screening research. And our podcast guest is Dr. Jeffrey Brosco, who discusses a wide range of topics, including the use of genomics to help end the diagnostic odyssey for families. So please definitely subscribe and share the podcast with your colleagues. Thanks.
Thank you, Dr. Chen. And Dr. Vogt, I will have you have the last announcement about the Paul Fernhoff lecture.
Thank you, Jennifer. Back in 2011, Paul Fernhoff, a pediatrician at Emory, who was very active in support of newborn screening and infant and child health, wonderful guy, passed away in his early 60s. And it was a great loss for everyone who knew him and for the newborn screening program in Georgia and so forth. So 2 years later, after his passing, Emory started an annual memorial lecture. And there were 7 of those until the pandemic. And the last 2 of those lectures have been virtual. And so now this year, Emory is presenting a hybrid lecture. There's going to be an actual personal attendance at on the Emory campus. And then it's also going to be zoomed out, and so people can attend virtually. And it's kind of remarkable about September. Paul passed away in September. September is Newborn Screening Appreciation or Awareness Month. And the topic of this year's Fernhoff lecture is sickle cell disease, and September happens to be sickle cell awareness month also. So I wanted to let people know that they could attend this virtually. Jim Eckman is the speaker. He's one of the true giants in public health and child health, minority health. and those kinds of things. He established, and this is written in his bio sketch that Jennifer has very graciously put on the screen for us. He established in the mid 80s, I think, a center at Grady Hospital, the largest teaching hospital in Georgia and in downtown Atlanta, and a center which is operated 24/7 for going on 40 years now. And there are several thousand patients that have been seen at the center. They are available. Physicians and other healthcare professionals are available 24 hours a day. It was the first clinic of its kind in the world. And Jim himself spent countless hours down there seeing patients. He saw pretty much all of those first 4,000 or 5,000 patients as they came through the clinic. He's a wonderful guy, just a very pleasant person, and completely committed to public health and the personal health of his patients. And one other point about sickle cell is that there are articles that say that the best thing that has happened for sickle cell affected patients up to this point is newborn screening. It creates a completely different trajectory when there's early identification by newborn screening. And Jim was a huge proponent of public health newborn screening in general, and especially for sickle cell. So if you have a chance, please tune in to the Zoom link. And Jennifer, I don't know how we're going to try to handle that. Is there some way we can make that available?
Yeah, if there's a link in the chat box that has a Zoom and the meeting information, but I think I think we have also an announcement page on the NBSTR website that we can put it on or
And
something.
the chat window is only available to panelists.
No, the Q&A question. There's a link in the Q&A question box.
Oh, I didn't notice that. Thanks, Jennifer. That's great that you.
Yeah, in the Q&A box, there is a link to the meeting that you stated, the Paul Fernhoff lecture, hybrid lecture. There's a link to the NBSTRN Summit, the registration link. And then also Stephanie from PerkinElmer put in the link to the posters as well about the assay. So if you guys have a few minutes, please check out the Q&A box for those links. It should be in the open section.
Jennifer, is that the link that you're referring to was put in at 3:02? Is it the last link in the Q&A?
Yeah, there's one at 2:59 and one at 3:02. Yep.
Oh, there is actually. There are two of them there. Yeah, and this is being hosted by Emory, and they've done a good job on the virtual lectures we've had the last 2 years. So I'm hoping that this all works, and it should not require a password. So I hope that all works out.
Well, thank you again, everybody, for your attendance in the meeting, and please check out our website again or follow us on any of our social media channels. So I think we're 3 past the hour, so I'm going to close it out for today. Thank you again.